Right, so thank you for joining us for this webinar. Um, my name is Andrea Stennett. I'm a research neurophysiotherapist. I currently work at the Bartms, with the Bartms MS service and at Queen's University of London. It's a pleasure to be here, and thank you for joining us on this very first thing Friday morning. So I'm going to be chairing the session this morning. So if you have any questions or any comments, please feel free to send through to us, and we'll try and get through those questions for you as we can. I'm also joined here with Ide and Amy. They will introduce themselves later on as well. So I'm going to kickstart this presentation, and the topic is preparing patients for their remote follow-up appointment. I have no disclosures. So I think just to give you an idea of how I'm going to move through the presentation, first of all, I want to explain to you the clinical context prior to COVID-19, just to set this presentation up. And then I'll give you an idea about how we've adapted through the pandemic, the pragmatic approach that we've taken. And just to say here that this is work in progress. So we're learning and doing as we go along. And then I will share with you some of the next steps. So as I said, I work with the Bartms service, and we're located in East London. We see approximately 3,000 people with MS. And in line with the current NICE guidance, we complete an annual review. So every year we would see our patients as standard. They might be seen for more times than that, but that's the clinical standard. They will have an annual review. So just to give you an idea of what we would normally do prior to COVID-19. So patients would come into the outpatient setting. They would see their consultant. It would be a face-to-face consultation. And then they would see their MS nurse specialist as well. If I'm in clinic at the time, I normally would do a series of outcome measures, and we call those the 3 tests. And I'll explain to you what that means in a minute. And then based on the outcome of those assessments, I may then enter into a discussion around disability management. So just to give you an idea of the test that we would normally do in our clinics, it's a 9-hole peg test. It's a measure of arm and hand function. We would also do a 25-foot walk test that looks at lower limb function and walking speed. We would also do the symbol digit modalities test, and this measures processing speed, concentration, and patient attention. And more recently, we've added the Abelhan questionnaire. So this is a measure of manual ability for people with upper limb impairment. So there are actually 4 tests, but we still call it 3 tests. So why do we do these outcome measures? For us, it provides a snapshot view of functional ability and cognition. They're quick and easy to do in a busy outpatient setting. So for example, if someone is mildly impaired, we can get through those assessments within 10 to 15 minutes. If someone is more severely impaired, it takes up to around 20 minutes, but not usually more than 20 minutes to get through all these assessments. We think also that it provides us the ability to monitor disability over time, and it opens up wider discussions for additional support. So based on the assessments, what I might do is initiate a discussion. So for example, the time 25-foot walk test, it's a quick walking test, but during that test, you can pick up a lot of things. So you can pick up whether someone has lower limb weakness, whether there is an issue with spasticity, where they might be at risk of falls. And if that's the case, I might then open up a conversation about what's going on. Have they been falling at home? Are there any near misses? And so on. And it gives me the opportunity then to either bring them back for a one-to-one session with a more in-depth assessment of functional disability, or I might decide to link them in closer to home with their therapy team. So I might do a referral to their physios, OT, speech and language therapists, depending on the situation. It also allows us to initiate discussions around self-management. And within a wider context, it also allows us to increase the quality of service that we provide for people with MS, because quite rounded assessments that we're doing. And it increases the collaboration between healthcare professional and person with MS. So we've been doing these assessments for over 3 years consistently now. And so you build up a little rapport with the patients. And the last thing, it allows us to identify patients for research. This is just to point you to a recent paper that was published by the team in collaboration with the MS Register, and it gives you an idea about how we've developed monitoring of our patients over the years. So then COVID-19 hit, and there was this massive change to our service. And it really changed how us as healthcare professionals and people with MS, how we interact with the healthcare system. So now the default mode was remote consultations, and face-to-face contact was limited. We're still able to see some patients face-to-face, but that's quite limited. And so we had to make very quick adaptations, and it required a lot of creativity on our part as well. So we found ourselves trying to navigate our way through COVID-19. And this is what the typical consultation would look like now. So a patient would either receive a video call or video consultation or a telephone consultation with their neurologist. But then for us, it started to ask the question, how do we bring the test that we would normally do face-to-face within the outpatient setting? How do we do that? And so we decided to initiate what we call remote testing. But we decided to use a pragmatic approach. And so there were some key aims as a team that we wanted to achieve. And the key one was we wanted to maintain communication with our patients because it was a very uncertain time for us and for them as well. We wanted to maintain that human contact. And we wanted to inform our patients about the changes to remote consultation and the switch to remote monitoring. And we wanted to communicate the importance of remote monitoring to keep track of their condition whilst face-to-face contact was limited. So I'm just going to share with you what we did pragmatically. So one of the key things was designing the communication tool. So we designed a clinic letter. We were very deliberate in our action. So we ensured that this letter was going to be on one page, and that the information that we were providing was short, succinct, to the point. And we wanted to give them an idea of the test we were asking them to perform. So this is just a small excerpt that I've taken from one of our clinic letters. So it just gives them a brief introduction and a brief introduction to what we're asking them to do and the test we want them to complete at home. And then we said to ourselves, because we've been doing these tests on patients only once per year, they may not remember how to do it. So what we did, we said, okay, we'll give them some videos, some demonstration of how to do it at home. So what we did, we linked them in with the Clinic Speak website. And that website, if you don't know, it's a very good resource. So it has the outcome measures that we were asking people to do. And then the other thing we said to ourselves was, okay, we're going to have a way for them to get the scores back to us. And we designed what we called a self-monitoring sheet. And this is not unfamiliar to some of our patients because we tend to use it in clinic as well. So we just modified it a bit, and that was what we decided to use for them to send their scores back to us. Other things that we did, because we know our patients were very concerned about COVID-19 and MS, Professor Giovannoni, he set up a microsite that deals specifically with issues around COVID-19 and MS. And so we created a link and we provided a link for them to actually read further information about it if they choose to do so. And then one of the things that we said, okay, since we have all our communication tools ready, we then decided that we were going to engage the Bartms patient advisory group. And so what we wanted them to do was to vet all the communication that we were going to send out to patients, because we know use of language is very important. One of the other things that we did was ensure that whoever we're approaching, they could access the team, whether it's via telephone, email, or post. So accessibility to the team was very important. And finally, equity. We wanted to offer remote monitoring to all our patients. We didn't want to create a two-tier system where we were deciding we were going to give it to this person and not that person. So we decided to offer it to all our patients. They then had the opportunity to opt in or opt out of it. So just to go in details about what we did. So for the person with MS, what we did, we scanned the neurologist clinic list in advance, and we would contact the patients. We would give them a telephone call, and we would explain to them what we're asking them to do in preparation for their remote consultation. We also explained to them that this is voluntary. They didn't have to do it, but we explained why we were doing it. And one of the things in terms of all the tests don't really need any equipment, but if they were going to do the 9-hole peg test, we then said, okay, we would probably have to send them out a 9-hole peg test kit. Some of our patients already have a 9-hole peg test kit because we would normally give this out in our outpatients clinic prior to, but it was for those patients who didn't have one at home. And then what we will do is follow up the telephone conversation with information either via email or post based on their preference. So I've put this slide in here because I'm talking predominantly about how we prepare our patients for remote consultations, but there was a lot of work that went into it behind the scenes as well. And so what we did very early on when the pandemic hit was we created a remote monitoring group. So it's a very small team. And we, at the height of the pandemic, we were meeting about once a week, trying to get this system up and running. And we worked in collaboration with the information governance team because we wanted them to be aware of what we were doing. And we also worked in collaboration with the IT service. So one of the things that we did was create an email account specifically around remote testing. So any information we send out to the patient would come from that account, and any information they send back to us, we would pick it up. And then what we would do would upload the scores to the electronic system ready to go for the remote appointment with their neurologist. One of the key things that we did as well, we designed a protocol about the key procedure, and that because it was something new for us during the remote testing, it was a reminder for us, but we've now been using it to train new staff. And it's very important because staff might go off sick or redeployment or whatever it is. So if you have key policies and key procedures about how to do it, that would help the team. So how are we doing 6 months on? So we started around May time. So we have experience of this now, 6 months on. There've been opportunities, but also challenges. So the opportunities so far, we've contacted up to almost 500 patients. So far, we've received positive feedback. Patients are largely happy to be contacted with the team, and they use this as an opportunity to ask further questions about their upcoming appointment. Some people felt that their appointment was going to be canceled, so it was an opportunity to say, no, it's going to go ahead, but this is how it's going to go. People were happy not to travel to the hospital, and one of the things that we've recognized since we started doing it is a whole thing around patient activation and engagement. People they're more engaged with us in terms of what we're doing, and we've created the tools for them to help to self-manage. People talk about family engagement, or I got my daughter to help me with the scores, and so the family interaction. It's really good to see. We've had some challenges though, and one of the challenges was around staffing. So in terms of redeployment and also additional tasks. So that's this remote monitoring is something new. So it's an additional task that we've taken on top of the other things that we were doing. We recognize also that not everyone wants to be monitored. So some people don't want to know how they're progressing over time. And we're very sensitive to this. And that's why we've kept it on a voluntary basis. So it's not mandatory. One of the challenges that we've had was difficulty to contact some of our patients. So maybe from the hospital, the phone call comes up as unknown ID. So maybe they block it, or maybe they just don't respond to that. Or non-personalized voicemail. So if there isn't a personal voicemail, we can't leave a message to say we've contacted. Digital confidence. That's that's, you know, we assume that people are really confident with digital technology, but we were using very low tech technology, just required a phone or maybe access to a computer. But we realized some people were even struggling to get those scores back to us. So they would just write the scores back into the emails that we've sent them. And that's fine. We've tried to make this as flexible as possible. One of the other things was also around the cost of the 9-hole peg test. At the moment, we do have our stock, we have the resources for now, but at some point we're going to have to order it. And then space at home might be an issue. So this is the last slide. In terms of our next steps, you know, what we want to do is really evaluate the experiences of people with MS, and also for the healthcare professionals, since we've started remote monitoring, we want to also automate some of the actions. So we need IT support. And the other thing is to evaluate the quality of the data from remote testing. So thank you so much for listening. And I have some acknowledgements here. It's a very small team. So I am open now for questions. If you have them, please send them through. I'm going to do the stop share and I will hand over to Ide. Thank you.
So thank you, Andrea. So I'm happy that you now clarified also for me all the work you do before I see the patients. So I will start sharing my PowerPoint. So hello, I'm Dr. Ide Smets. So I work as a consultant neurologist at Bart's MS London. And I've been also, I've been employed through helping the team out through the first wave and second wave of COVID-19. And this actually meant in practice that all our clinics are now conducted remotely. So we hardly see anybody anymore face to face. And this has obviously entirely changed how we conduct clinics and has made it sometimes difficult to get a full clinical picture of the patients through this kind of communication. So I will explain to you how we did it and how I think if you would be in the same situation, how you can get the most out of these remote clinics. So I have no disclosures related to this talk. So first of all, the way we do it is, so we use the AccuRx platform. So this is an NHS licensed platform, and it implies that you enter the NHS number and the date of birth of the patient in a sort of online application, and then the patient gets an ordinary text message that contains a link. And by clicking on that link, a web application opens that allows to have a video clinic. Very often, I must admit, it sounds elegant, but for some people, it's obviously still a hurdle. One of the biggest things that has come up is that people consider this link in ordinary text messages as a sort of spam, which I understand because every other message I get in there is also spam. So sometimes it's really necessary to also call people separately and to inform them that you sent this text message, that it's safe and that they can follow the link. This way some people also do regular phone clinics, but personally I find the video clinic is the best approximation of a face-to-face clinic, and it also gives many other advantages. So you can actually see how somebody's doing. They can also go and fetch, for example, their medication, can show you the boxes. So it really allows you to get more information out of this clinic encounter. So for myself, I've summarized all the advantages and disadvantages of the remote clinic. So I think it's very clear that it's a very safe way of seeing people with MS. There is no risk, so it's COVID-19 free. So they don't need to come to the hospital. They avoid unnecessary transport, very often on public transport. So that's definitely an advantage. It's also true that it's very flexible. So you don't need all these clinic room reservations anymore. You don't need to take into account that counter staff is available, that logistics, transport, all these things, you can do them actually from any location and any time around, any time during the day. So it's really, you're not bound to the regular clinic hours anymore. People can, and this also this is also true for patients themselves. So they don't need to take a leave to attend clinics. So they can do it really from their workspace or from home without having to arrange babysits or anything else. And very obviously, it's also true that when this would become not the new normal, but the standard of practice in the future, it would clearly lead to a reduction in cost reduction in terms of infrastructure and staff. But this is obviously, these are the advantages, but very obviously there are also disadvantages. I think it's very clear that you can't get, it's difficult to get reliable clinical information out of such a remote encounter. And so that's also what the remainder of my presentation will be about, how to get clinical information out of virtual clinics. In addition, also, I think when using the video platform, it becomes as good as it gets, but still, yeah, it's not real. So one way or another, it feels unsatisfactory after you had the remote clinics. So yeah, it's obviously remote. And furthermore, I think it also, the fact that everything is now conducted remotely and that people kind of adds to the idea that the hospital would be an unsafe environment and that people need to avoid it at all costs, especially because we are almost conducting everything remotely. So at this point, I think we should also, we shouldn't frighten people to contact us. And if they would really want to see us, it should be a normal thing to ask. So, but maybe by organizing everything remotely, we kind of use this sort of threshold or anxiety for people to ask to come in if they would feel like it. And yeah, I don't think this is very quantifiable, but I do think that seeing people only remotely, it kind of introduces a sort of barrier or sort of threshold for empathy. I can't, it's very difficult to quantify this, but I think you have to admit that it's different when a patient is in front of you, the way you engage and commit to his cause versus when he's on the other hand of a video screen. So this is for me the pros, and these are for me the pros and cons of the remote clinics. So it's definitely true that there are many advantages. So I think they will remain a way for us to provide MS care in the future. But I think the real question for the future is how we should balance this with face-to-face clinics. So as Andrea also told you, this is not the only thing we've been doing. So we have remote clinics, but we have also remote monitoring. One of the things that she didn't touch upon is that we also arranged for people to have home phlebotomy service. Some of people have also home infusions of, for example, natalizumab. And then indeed, as Andrea told you, we also launched this MS Selfie website. The biggest advantage of this website was that people could ask COVID-related questions. And as you probably all can agree on, many people had the same kind of questions related to COVID-19. And so this way they could scroll through other people's questions, and it avoided our MS nurses to have to reply to all these emails with the same kind of responses. So people were, so we kind of reduced the burden on them. And then so what I will now talk about is so how to get clinical information out of a virtual encounter. I know this sounds probably very daunting, but we made an effort to realize this. Together with Dr. Saul Reyes, we thought about a virtual neurology examination that contains 3 parts, and it allows you to do a sort of screening evaluation of the principal neurological functions. So the first part of our virtual neurology examination is the observation while sitting on a chair. This is also the most straightforward part of the virtual examination. So here you see some snapshots on how we do it. So it's very important that the patient positions himself approximately 0.5 meter from the camera. And then the biggest advantage of this part is that you can actually show them how they can do the specific tests. And so they can just mirror you. This part is obviously aimed at screening for distal versus proximal motor weakness. It is a screening test, so it doesn't allow you to thoroughly evaluate skeletal muscle strength. So whenever the screening test would point in that direction, I think the only sensible thing to do is to invite them for a face-to-face clinic. So now I will also show you a video so that you can get an idea of how we do this in practice.
This is the first part of your neurological examination, and now we're going to evaluate your arms. Can you please move away from the camera about half a meter? Now, can you please put your arms all the way up in the air above your head? Can you please now put your arms all the way up in the air in front of your camera and close your eyes? Open your eyes and please roll your fingers in front of the camera like this.
Okay, so this is a glimpse of the first part of the examination. So then we move on to the second part. So the second part is also while sitting on a chair, although the title doesn't say it, but it also, now we observe people from close-up. So this, you can already guess now, is because we want to evaluate cranial nerves. And so for the cranial nerves, so our version of the virtual neurology examination, it kind of entails tests that cover almost all cranial nerves apart from the vagus and the olfactory nerve. So for some cranial nerves, this is very straightforward. Obviously, for the trigeminal or the spinal accessory nerve, you don't need a lot of imagination to think how you would be able to evaluate it. But for mainly the cranial nerves that are involved in eye movements, this can be really tricky. So that's why, first of all, there are things that you can't do during this virtual examination. And also we have tried, for example, a confrontation test is impossible. And so if you want more detailed information about vision, we find the eye handbook application very useful. So this is an application that you can download freely from the app stores. And it allows you also to evaluate visual acuity, so color saturation, it really is very useful if you would have any doubts on the patient's whether he has visual symptoms that are relevant. So this is a sort of asynchronous evaluation that you would need to instruct people on. So in addition, so as I already suggested, it's very important that patients position themselves at close enough to the camera, but obviously it's also important that they're not too close, because then and you also can't see anything. So that's why we introduced, we tested many things, but that's why we ended up with the one index finger rule. And so this implies that people position themselves at an index finger's length of the camera. And we feel that this is the exact right kind of distance. So just enough to allow you to see all the cranial nerves, but not being too close to the patient, him or herself. But in addition, the problem is that even the one index finger rule is not sufficient to make this part of the examination go smoothly. So this is really the part where you can't improvise, and where the way you instruct people really will determine whether you can deduct anything from it. So that's why I would recommend you to listen very closely to the instructions we give during this part, as they are really intended to avoid people obliterating the view from the camera with their hands or with other objects, and allowing you to evaluate the part of the cranial nerves that you're interested in. So I will show you next. This is the second part of your examination, and we will be looking a bit more closely at your face. Can you take your flashlight, turn it on, and position yourself at one index finger's distance between the camera and your nose? Okay. Can you position the flashlight lateral to your eye and slowly move it inwards? Stop. Can you close your eyes for at least 5 seconds? Open. Okay. You can put the flashlight on the sides. Can you now look upwards, downwards, left, and right? Okay. can you take your pen and move the pen between the upper border of the camera and the skin between your eyebrows? So, so maybe I should have given you the instructions then separately, but anyhow, so you see that, so we specifically ask the patients to position the flashlight lateral to their eye and then gradually turn it inwards. So this means that, so it's very important that this is the only way that, in our opinion, you can visualize the pupils sufficiently. Because otherwise, when you cannot give them a fixed position of where the flashlight should be, because the fixed position, there is no fixed position. So you really have to judge it on the moment. So, and then you also saw that we instructed people to put the pen here between the skin, between their eyebrows, because this is really the only way you can observe this, because if you ask people to keep their finger here, they will obliterate a view. So now there is also the third part of the examination, and the third part of the examination is the observation from a distance. So the observation from distance is obviously intended to evaluate lower limbs. So again, the same principles apply as for part one. This is a sort of screening examination, and it doesn't really, it doesn't allow you to do a very thorough evaluation of skeletal muscles. And then what you can evaluate is, or what we at least included, is the Gait and Romberg's test. So this examination, as you see here, will include full frontal evaluation and lateral evaluation. So the full frontal evaluation is very useful for Gait, for Romberg, and to evaluate truncal movements. But so the lateral view is really necessary for the tip, if you want to evaluate, for example, tiptoeing. Importantly, it's people need to position themselves in a way that you can see their feet and their legs, and it's very important that they don't direct the camera, so they don't position it obliquely at the versus so directed at the ceiling, but it really has to be perpendicular, so you can get the most out of the very often small spaces you will perform this virtual examination in. So here's also a small video. It doesn't matter, there is no sound, so you can just get an idea.
This is the third part of your neurological examination, and now we're going to evaluate your gait. So I want you to please put your camera on the floor as vertical as you can, so we can see your feet, and then please stand up about 1 meter away from the camera. Can you please stand up on your right leg? And now I want you to hop on that leg 3 times.
So here we make them.
Can you please stand up on your left leg?
The camera is positioned really perpendicular, so
and
you
now
have
I want
this
you to
view.
hop on that leg about 3 times. Could you please turn around and then walk away from your camera?
Okay, so my neurological examination wasn't entirely normal, maybe. So anyhow, so this is how you can get the most out of part 3, so the lower limb evaluation. So if you would be interested in seeing everything and having the full experience, so I would recommend you to go and visit our website www.virtuex.org. There you can find all the videos we have made with all the explanations. And it would be even better if you have experience doing remote clinics yourself and you have found your own way of working, of getting clinical information out of it. Feel free to contribute to this website, and so we are happy to learn from all of you. So thank you for your attention, and hope to hear if you have additional questions at the end. So I think now it's Amy's. We move to Amy's presentation. So I'm looking forward to hear about your insights.
So today I'll be talking about preparing for the MS, for a virtual MS consultation. So it's what we do beforehand, before the patient gets to speak to the doctor or the nurse. So my declarations, nothing that interferes with this. So just a bit brief background about where I work. So I'm a community nurse. I work for Southern Health Foundation Trust and cover over about 850 patients. So we have equivalent to 2 full-timers working across 5 community hospitals, and we come from two acute hospitals, Southampton Hospital and Portsmouth Hospital. So pre-COVID, we had about 12 clinics per month and 3 drop-in sessions. So these were with MS societies and different hubs that were in our area, so that we would go there as well, just so it wasn't necessarily clinics, but just to add information. And we did approximately 15 home visits per month. And then, as you know, things changed. So we tried to work a way to do things virtually. And so we followed the NHS England guidelines, which was to risk assess and just to ensure that there was low patient harm, which there is no harm to going virtually. We implemented a contingency plan, and especially for IT failure, and that was quite straightforward, which was telephone call if internet did not work. And then after our first live day of going virtually, we had a day of reflection and just to make amendments. And since we went virtually, we started getting feedback right from the get-go, because we knew things weren't going to go smoothly and what to change. And whilst we think what, you know, as professionals, what we'd like to have out of a consultation is not necessarily what a person with MS does or wants. So we offer video consultations for every appointment booked. And as you all know, it's just a way of getting a patient to meet us without the need to come in to visit us. So the pros would be that patients were able to not take time off of work. They were able to bring somebody or a friend into the consultation, again, without them having to have time off too. So how do we prepare our patients for virtual clinics? So before each clinic, we send a how to prepare for a video consultation leaflet to our patients. This includes, we go through technology types, depending on what they want to discuss. So is it the right equipment? Do they need an iPhone or is it a laptop? Depending on what needs to be discussed. If it's mobility, maybe a laptop's a bit better. If it's just a catch up, some people just prefer an iPhone or smartphone. So also just to prepare them to make sure everything is set up beforehand, so they've got enough battery, the camera's working, the link's correct, and also the lighting. We've had quite a few experiences where it's so dark that we can hardly see what's going on at all. So, and also just to inform them that being comfortable, having somewhere quiet and some space and where they feel comfortable to talk and to be quite open, so not at work. And just to prepare some notes beforehand, as we would normally with a face-to-face, you know, the top 3 things you want to discuss, just so they can, you know, assure to get the same out of the clinic that they did beforehand. We also go through symptoms. So if something's difficult for you to hold a device, maybe we could use some cardboard or some books to help prop it up, to have a list of medications ready. Just to explain that there's the loudspeaker optional, so that they can invite friends or family or carers into the conversation also. And during the time, we noticed that the people didn't like to talk over us. If we were talking, there would be that mix of communication, and they looked a little bit worried or anxious if they wanted to say something. So we do say at the beginning of each conversation is, if you do want to say something and you feel a bit scared or anxious, just to raise your hand or make a gesture, so then we know when to stop and to let them talk further. Oh yeah, and just to go back to say that to have the telephone number again in case of IT failure, comfortable shoes so that we can measure walk-in, or if they want to talk about walk-in, and also to have suitable equipment to hand. The reason for that is that a lot of our patients that we see at home have new equipment delivered, or there might be a change or a break. So just so that we can see what their new equipment is, if it's working for them, or just to suggest any changes. So we're really lucky here. We have two MS coordinators who offer really good advice for those who are technology shy. So what this means is that our patients have the option to contact our MS coordinators to run through a dummy test of a virtual consultation. They also send reminders and text messages out close to the appointment. And they also do the auditing, so they contact the patients post-consultation. So this is what our system looks like. We use something called Visionable. This is the booking system, and this is what the patient has the link for. Again, this is the next slide. It's just a quick link, and it's quite similar to Zoom actually. So the feedback that we received is, so how much has it supported the lifestyle? So we found out that most patients, it did support their lifestyle, up to 57%. Most people would recommend it to a friend. Most people found it easy to use, and it allowed people to take less time off work. This is a graph just to show just the increase in consultations. So at the beginning of the year, we didn't really support them, we didn't really do them, and you can see up until next year that has increased. Again, just to kind of go over the pros and cons. So the cons would be, so some people find it uncomfortable and are video shy and unable to see some subtle changes. And we also found that newly diagnosed, it was quite hard to do the consultation. So we'd still like to do the face-to-face. The pros were, we have a really large geographical area, so we've saved a lot of money, time and petrol.
Thank you so much, Amy. Now, just to say, if you have any questions, any comments about anything you've heard, please free to send through your questions. The other thing I would say is if you're doing something similar within your team, please feel free to let us know as well how that's going on, how that's going for you. So I have a question that I'm gonna kick off with. So Ide, one of the questions I was thinking of asking you is how do you see the balance between remote testing and the virtual clinics?
Yeah, obviously, if we do virtual clinics, remote testing is necessary because it would be very contradictory if they have to come in for the 9-hole peg test and then we do the clinic virtually. So I think those two are really intrinsically connected. But so anyhow, if you so I do think that in the future, but that's also what I was wondering because once you start to go remote monitoring, when you do your remote 9-hole peg test, is there any information on how it correlates with face-to-face and you instructing them in clinics? Because can we just switch remote monitoring to face-to-face monitoring? Is it possible? Is there any evidence on that?
So we need to do there's a lot of work that actually that needs to be done. The interesting thing is that we've actually tried to do remote monitoring in the past, but for whatever reason, the uptake wasn't as good. But now, because I think there's no alternative, it forces us and it forces patients as well in a way, if they want to get their scores back to us. What we do is we link them to the Clinic Speak website so they can have a look at how the tests should be done. But we're gonna have to validate that. The good thing is we've been doing it for years now. So we now have in like face-to-face assessments, so assessments that have been done in clinic. So we need to look at the data that's coming back from the remote testing and see how that marries up. But that's one of the work that we're gonna have to do.
But one of the things I wondered is, can people secretly practice? Because, you know, when you send this 9-hole peg test to them, which value do you get sent back? The one after they tried it for 10 times, or, you know, because when they come into clinics, you do it once and they don't have the cardboard 9-hole peg test to test at home. Most of them don't. But obviously, when you send it to them at home, you know, maybe your results get biased in a way because, they have a lot of opportunity.
That's a good point. Actually, in clinic, they'll get a practice run and then they get to do the test. I suppose it would depend on the patient. So you have some patients who are quite competitive and they would probably be practicing, want to beat their scores. What I find from some of the feedback that we've been getting back from patients is it's around you know, or I'm doing it with my daughter, or I'm doing it with my husband, and we're just trying to see who gets the best scores. So it's some work, and we're going to do some, ask them about their experience. And it's one thing that we're going to have to ask and just see, but there's a lot that we need to do in terms of validation. And which leads me to my next question, Amy. Do you ask them to do anything to send back stuff to you guys, and how are you finding that?
So I think we have a bit of a different approach to it, really. So I think the majority of our patients, rather than assessing them, that we normally find that's done with the physician, and we're there more for emotional support, mental support, and just to ask really the questions and the touch base like point between the consultant and us and the patient. It's just the midway point, and to let the consultant know of any changes. But we don't really do many tests in the community, and it's just, I think a lot of our work as well is just to keep on top of the monitoring and side effects. And I think that's where we're kind of finding, especially community nurses, being drawn really quite heavily towards, is just trying to keep on top with the protocol from the different DMTs. So I mean, it's something that we'd love to do, and you know, to be more involved that way, and especially for those who aren't on treatment as well. But unfortunately, I think that's where we're kind of drawn to at the moment.
Okay. And while I have you on, Amy, I'm going to pose this question. So we have a question that's just come through. So I'm going to ask you first, Amy, and then I'll ask Edie as well. So the question says, have you been running MDT virtual follow-up clinics? If so, how were they received by patients?
So we have an MDT clinic every Friday, and it's the same structure really. Nothing's really changed with the way that information is disseminated down to the patients. I think our MDTs are a lot better at the moment, just because more people are able to be involved. I'm not having to drive over to Southampton to be part of it. So I think it's kind of opened up such an easy way for community people especially. So nothing's really changed with regards to our MDT. No, don't know about you, Edie.
Yeah, so I totally agree with, from a point of view to detect side effects, it's just what you don't ask, you don't know. And that's the same rule in virtual clinics as in face-to-face clinics. I don't think that you can, so the side effects, you detect them by asking. But there are also side effects obviously that require lab results. And that I find is a difficulty with remote clinics, because for some of the treatments you need, you want to know whether the lymphopenia has resolved or whether it is liver damage. And so GPs were not always keen on doing these monitoring blood tests. So actually for some people, we had a remote clinic, but then people still needed to come in for the blood test in Royal London Hospital because the GPs weren't keen on doing these tests. So we didn't kind of save any transport then in the end. So I think, so that's the difficulties. So we do them virtually, the MDT follow-up clinics. And so for the majority of the side effects, it's just about asking about them. But for the biochemical related side effects, I felt that we try to do that also remotely by engaging with GPs, but many GPs didn't, just refused. And in the end, people still had to come to the hospital. Yeah, that's something that would that obviously makes this kind of way of working less attractive, because yeah, then it's a bit unfortunate that they come to the hospital for blood work but not to see you. So
thank you. And just while I have you there, Edie, while you were going through the consultation, how would you further validate your methodology of the virtual neurological examination? Whoa.
Yeah, so that's a very good question. So it's true that at this point, this is, so the way we conduct the virtual clinic is mainly instructed by practical reflections or practical motivations. So we have tested this among us, and we felt that this way of instructing people is the most efficient way to get information out of it. But we didn't relate this to how efficient it is. So if, for example, somebody would contact you with a relapse, how efficient this virtual neurologic examination is compared to the face-to-face evaluation. So that is something that we would need to explore in the future. I think the problem is just that at this point we don't do face-to-face evaluations. So, so it's very difficult to make a direct comparison between both. But I think that would be the way forward to see how this holds up against our golden standard. So the golden standard of face-to-face, and whether actually you detect more, but not more, but meaningful more in the face-to-face that would change your practice. And so very often, obviously, when you have these kind of situations, it's really black and white. Is there something that you find abnormal versus, and it doesn't matter exactly how much, but if there is one thing, it probably will trigger a new set of examinations. So I think it's reasonable to assume, but obviously unscientifically at this point, that the virtual examination will succeed in that purpose. So the yes or no question, do I have to ask additional examinations? Do I have to take this further or not? But this is indeed a source of ongoing examination, and so we will try to validate it in the future. Okay. So, but Andrea, I also wanted to ask you, so what do you do actually if people do not send you back the scores? Do you chase them up, or just do you drop it, or how good are you at getting all the results back?
That's a very good question. So when
that's general knowledge. That's really general knowledge for everyone. Everyone wants to know your secrets.
I know. So when we actually started, we had this wonderful plan, and we said, actually, we're going to contact people a month in advance. And one of the reasons why we said that, it will give us enough time to contact the patients. It will give us enough time to get the 9-hole peg test out to them if they don't have it. Give them enough time to get the scores back to us for us to upload it. I must confess, we're yet to meet that target. So we're actually, but we have an additional staff as a person that has just started with us actually, which is brilliant because it's really helping to support us. So what's the current, where we are at the moment, we're like contacting people 2 weeks in advance. So it's still pretty good because what happens is the 9-hole peg test goes out pretty quickly. So if we order it today, it is with them within the next 2 days. So it still is giving them enough time. So ideally what we want to do is contact them a month in advance, and then if they haven't sent the scores back, contact them 2 weeks in advance. That's not happening at the moment. We're not getting chance to prompt, so because of staffing issues, so that's work to come, but that's the standard, and that's what we'd like to get to.
But may I ask you, so with how many people do you work on this, for how many MS patients?
Say again?
So with how many staff members are we currently working on this? For how many clinics per week, or so what's the ratio?
Yeah, I know. So that's why I said staffing is an issue, right? So we have 3,000 MS patients on our books. We don't contact all of them at once. So what we do is scout the clinic list, but the clinic list, because it's virtual clinics, have grown massively. Yeah, so you're talking about one clinic could have 18 patients, and we have like 3 clinics over the week, for example. So that's a lot of patients to contact in 1 week. We talk about the team, but in actual fact, it's 3 of us that's doing the work. When you say team, it sounds big, but it's actually a small amount. We've had an additional person now, so that should help things. She's joined about 2 weeks, about 2 weeks ago now, so that's going to help us massively. But yeah, it's voluntary. So we depend on people to get the scores back to us. What I do find is that if they've done it in clinic before and they know what it's about, then they are engaging more. there is some skepticism though about how we use the data. And so I think we have a responsibility to be very transparent with our patients around how we're using this data. So it's for clinical purposes, and we make it very clear. Some people are skeptical that we're going to contact, government agencies saying, well, like, no, it's purely clinical data. We're not telling anybody that you can walk X amount speed or whatever. That's not what it's about. It's purely for your clinic, for your clinic data. So I think there's some education around that. And as I said, some people just don't want to monitor themselves, and that's fine. But what we do is, say they say no this year, next year, we will still offer it to them as an option, because what we do find is that people also change their minds. So maybe they don't do it this year, but next year they're like, oh, I probably should do it. And we just offer it to them.
Okay. No.
But so far we've been getting back, we're getting the engagement there, which is pretty good.
So
and
of all the tests you sent out, what's the percentage you get back?
So that's what we need to look at now. Now that we have this new person starting with us, we can start now having a look at the data to see how many scores we're getting back because of the time limit. So we have 2 weeks. And what I'm finding is sometimes patients send the scores the day before the appointment. So if we don't pick them up there and then, you might not necessarily have it to go into the appointment. We still add it, but the idea is to get it on the system prior to the consultation. So if they ask you, or how do you think I've done, you can have a look, and you have the other year's scores as well to compare it to.
Yeah. Okay, thank you for your clarification.
So I think that's it for now. Thank you very much for joining us. It's a pleasure to be here. And I just want to say thank you to the MS Academy as well for inviting us to share with you about what we're doing about remote monitoring. Thank you.
Okay, bye-bye.
Bye.